Good afternoon, everyone. My name's Akash Patel. It's an honor to be here. I want to thank Pat, first and foremost, and the American Heart Association for organizing this space and inviting me here to be a part of the conversation. I also want to extend a sincere thank you to the patients who are here with us today. Their courage and their partnership and willingness to share is really what drives the future of what we do here, so thank you. So I'm currently a second-year general cardiology fellow at the University of Chicago. My journey into this field has really been grounded in curiosity, collaboration, and the simple belief that the future of cardiovascular care really depends on our ability to connect medicine, technology, and the human experience. Before fellowship, I got my medical degree and MBA at Northwestern University, and that's where I really became interested in digital tools, data, and clinical insights that can help us improve prevention and chronic disease management, and especially for communities that have been underserved. And I think that's a lot of what I've seen topics about today. You know, we have all this technology, but how do we really help the people who have really been underserved throughout our history? And as a trainee and as an early career physician, I feel like it's our responsibility not only to advance science, but to build bridges between disciplines, between innovation and implementation, and most importantly, between the ideas and the people that we're really trying to do this for. So I'm humbled to help open up this panel, and to learn from fellow early career physicians, and to share space with patients whose voices really are essential in shaping the future of brain and heart health. So thank you again to Pat and to AHA and our patient partners. And with that, I guess we should get started with the panel.
Hi, everyone. Good afternoon. Welcome to Next Gen Leaders, Early Career Voices Shaping the Future of Brain and Heart Health. So I'm Lindsey Williams. I'll be the moderator. I'm one of the non-physicians. I'm a nurse by training and background, and the director of our hospital at home program at Cedars-Sinai. So kind of at the junction of technology, of meeting patients where they are, of kind of what's the next generation, you know, of these models of care. So very happy to kick off this panel with these established physician leaders. So would we like to start with intros? Marat, would you like to start?
Oh, I got one. I was hiding it. Hi, my name is Marat Fudim. I'm a heart failure cardiologist at Duke. I trained at Vanderbilt before that. I'm originally from Germany. And I've been on faculty now in my 6th year. And I've been in the intersection of research because I run our research endeavor for the Heart Center, and in the endeavor of device technology. I run a remote monitoring clinic, device heart failure clinic. And so that's where I fell into the AHA. And I've been involved with the AHA for many years. So I've been helping with the Early Career Council. I've been very happy to be part of the Health Tech Innovation Council, and see all the quality initiatives and the research initiatives that come out of it.
Great. Hi, everyone. I'm Nino Isakadze. I'm cardiac electrophysiologist at Hopkins. Year and a half into my faculty position, I direct Atrial Fibrillation Clinic at Hopkins and our Center for Clinical Trials. And my research is focused on atrial fibrillation and digital health.
Hi, everyone. My name is Efi Andrikopoulou. I'm a cardiologist with expertise in cardiovascular imaging and cardio-oncology. I'm with University of Washington in Seattle. And my research is on using AI and NLP and language models to streamline care, make sure all of our patients receive the same high-quality care, irrespective of their backgrounds. And on my free time, I am now getting more into the company and startup aspect of work by helping out startup companies.
Amazing. Yes.
And again, I'm Akash Patel, one of the second-year general fellows at University of Chicago.
Thank you. So I'll start actually with you, Dr. Patel. So many of us here, just hearing very quickly about our backgrounds, are all trained in very traditional models of care, but you're each kind of driving innovation in different ways, right? We heard about technology, we heard about imaging. So what inspired you to push the boundaries in your field?
Yeah, so, I grew up in Chicago, and I went to medical school in Chicago. And as part of that, I love Chicago, and it's a very diverse city, but it's very segregated in many ways. We do our primary clinic in different neighborhoods in Chicago, and the one I was in is called Austin, and a lot of the patients, we have up to 50% no-show rates. It's a pediatric clinic. And I noticed that, we're learning all these things to help these patients, but it was impossible to do them if they don't show up to clinic. And so I was, as I was training in medical school and I was in business school, I was really inspired by seeing all the technology that's coming about that maybe it can help us outreach these patients and kind of bridge that gap. And that's what I'm excited to see every year when I come to this conference.
Thank you. Effie, same question.
Kind of very similar. So I realized early on that our system is broken,
Yes.
and I will say it just to make the point. I know not everything is bad. I know that, and there's good things that we should capitalize on and invest on and learn from our successes. But I think at the same time, there's a lot of opportunities for improvement. And that reflects both on the clinicians and on the patients. Sadly, anything that affects the clinicians is going to affect the patients. And so experiencing firsthand clinician burnout, how fragmented, siloed, how broken and dysfunctional our system is, and how many opportunities there are for innovation and improvement. That was one of the things that that pushed me to, like I said, to work on this both from a QI and research standpoint, but also to now start also working with the company side of the health tech side of things,
Yes.
Bringing in the clinician insight.
Thank you. Yes.
Yeah, I mean, similarly, everything starts with a patient. And when you're caring for patients and you realize that you cannot really translate the best evidence and guidelines into patient care. So specifically in my case, it was atrial fibrillation and risk factor modification is class 1 recommendation by guidelines. But because of lack of infrastructure and cost, we have not implemented those risk factor modification in practice. So digital health tools really represent that, tools that can enable translation of the evidence-based recommendations at scale. So this was the biggest motivation for me to proceed with the digital health tools.
Thank you. And last but not least.
I'm not sure maybe how I fell into the space of innovation, not necessarily digital health, but for me it was initially, when I came to the US, I actually started in the startup industry. And I worked in an industry where I saw how quickly things can move, to then only be a little bit disappointed how slow things are in academia, in a traditional academia.
Absolutely.
But I took that learning on that it can be done through partnership. So that's why I've been partnering early on. Now into the digital space I fell by the virtue of care delivery. I recognize that the majority of care is delivered in the ambulatory setting, and our ambulatory care delivery tools are restricted to EMR, phones, video, and digital solutions. So
Right.
I've been getting more into the toy space, and cardiology has the benefit that we actually do RPM. RPM is reimbursed. RPM is actually at scale.
Reimbursed-ish.
Sure.
How
Depends.
many data points?
Yeah. Well, you got to start somewhere. I mean, if you look at some other spaces where
There's no payment
hypertension
model,
is
yeah.
struggling and certainly cannot scale, the kidney space is struggling. So I think we're doing okay that we at least have a platform.
Right.
But that allows us to test. If you have an environment in which you can deliver ambulatory care, now you can test novel technology. So that's where I fell into the digital space.
Thank you. Such different perspectives already, right? We're already getting to the crux of the model, right? Because how are we paying for this? Like, how are we implementing this with our patients? So, Nino, I'll start with you with this next question. So we've talked a lot about AI, data-driven tools, and really at the heart of this session and of this conference. So how are you, just to get into more detail, leveraging these technologies in your work? And then what impacts have you seen so far?
Well, technology has, impact that is, you have to take different populations into account. So in our case, we really took this challenge of guideline implementation, as I mentioned earlier, and we're leveraging multiple different aspects of technology. So this is smartphone apps that Dr. Marwell is here, co-founded a company called Corey that we are leveraging for smartphone education. Also, wearable technology like Apple Watch, and we have partnered with Apple to leverage the wearable collected data that is used by everyone, a lot of our patients in everyday life, and also virtual coaching. So you see like a different aspects of remote and innovative care delivery that we are leveraging. And we developed like a 12-week program to implement the risk factor modification for patients with atrial fibrillation. So we started with a human-centered design approach where we went to the patients themselves. So this is very important, like including the key stakeholders or key parties, patients, clinicians, hospital administrators, from the very beginning of the intervention design. And together with them, we came up with the final version of the intervention, that we then evaluate in the pilot study. It's very important for when you are evaluating new technology to test, and iterate on the intervention. And then after doing a pilot study, we got to a large clinical trial. So it is, that is currently ongoing. So this is a process where we learn that engaging patients and other key stakeholders when you're leveraging digital health tools is very important.
Thank you for that. Marat, would you like to share a little bit more, kind of same question, getting a little bit more into the details of, you kind of talked about two kind of aspects of your work. Could you describe that in a little bit more detail?
Well, maybe what the goal of my work in the digital health space is, for me, it's like a restaurant menu. When we set up people with digital health tools to manage them in the ambulatory setting, that not every device or solution fits for everybody. For somebody it might be an app, usually some hardware involved. For some it's an implantable device for remote monitoring. Somebody it's a patch, for somebody it's a scale, it's a bracelet. And what we're doing in our lab, clinical lab, we test those platforms. Some are commercial and well reimbursed, some are not well reimbursed. So we have to find out how to also pay for things.
Yes.
But we, at the end of the day, test many, many different things at any given time point, at least 5, 6 different technologies that we're testing. Not all of them will then be implemented at scale. We have 3, 4 technologies that are implemented at scale in thousands, but another 4, 5, then 6 tested in very small pilots, 10, 15. And then that's me on a small scale for our patients. But now comes the big leap.
Yes.
How do you introduce it to the system and scale it beyond your practice to the other hospital systems, and then advertise it, create protocols around it, so now it can be adopted by the other neighboring hospitals and beyond. So that is the hard part.
Yes.
I think testing things in a pilot is one thing, scaling into a large clinical trial is a whole different thing. Now making it commercially available, sustainable, reimbursed, woo, big deal, big deal.
It's an entire career. Yes, thank you. Effie, same question to you. Kind of, what have you seen, kind of early successes, and what kind of challenges are you seeing coming from scaling, implementation, reimbursement?
Yes. So the work that we've done initiated within our echo lab, but really impacted the entire health system because we do echoes on any given patient, outpatient, inpatient, emergency room. And so we jumped right into systems, and that's what really got me very passionate about systems redesign and studying what makes a system effective versus dysfunctional. And so back in 2020, when I was with University of Alabama at Birmingham, we partnered with an external company. This wasn't an in-house work, but we partnered with an external AI NLP-focused company, and we built NLP-based algorithms that identified patients initially with different types of valvular heart disease. And once we would identify them based on echo reports, we would automatically send notifications to the ordering clinicians in basket that said that, hey, your patient has been identified as having, let's say, severe aortic stenosis, and based on the latest ACC/AHA guidelines, they may benefit from being evaluated by UAB structural heart valve clinic. And here's how you can do that. And so that, I mean, it sounds straightforward, but again, we had to engage with all of the stakeholders, both within the echo lab, outside the echo lab, the heart valve group, all of our cardiologists, as well as the entire medicine department and surgery, but so that they were aware that these notifications would come their way. And we customized the notification so that the structural heart group would not receive them, obviously, because they don't need to be told what to do. And that started focusing just on disease states that can solely be diagnosed based on echo reports. So just one single data source, straightforward detection, and one straight line to appropriate referral and management. Yeah. And then that got expanded to getting access to the rest of the EHR to build NLP algorithms for AFib patients who may benefit for Watchman, heart failure for GDMT, sudden cardiac death risk stratification for ICD referrals, and now we're working on others too.
Yes, thank you. And something that I've heard so far, even just between the three of you, right, is that you have to do, of course, all the testing, the experimentation, right, in your lab, but when it's time for scale and when it's time for spread, you have to be super laser focused. Like, you don't click all these 3 buttons, because we all have the burden of documentation and too many things that we have to put in the chart. Just give me 1 path, maybe 2, that I could choose from to if you really want me to actually implement this and use it, right? So, but I'm sorry, yeah, Marat, did you?
No, actually, this reminds me that, the same challenge I go from my space, where well-chosen paths, you have somebody in Equilab, somebody in the EP lab, somebody in heart failure space, where we all have to go through a pilot phase and something works and scale. It's a little bit frustrating sometimes that this is done at every center, in every division and subdivision, by champions.
Right.
Sometimes multiple champions.
Right.
Competing interests, people stepping each other's feet. In the perfect world, there will be one task force that does it for the whole system.
Right.
One task force does it for the country and tell you this is the one you have to go with, right? I mean, that would be sort of antagonistic to the beauty of the capitalism and the free market in the United States, right? That way but this is the reality, is that we keep reinventing the wheel at each institution, doing all the same learnings over and over.
Right.
So when I go around the country and meet with my partners, we have often the same learnings. We could have saved us a lot of time, not have to redo the learnings. If we just share them and implement together or through a templated approach, rather than everybody has to learn it again from scratch.
Right.
Well, I think that data sharing becomes a problem. Like all academic institutions we all face, like every time we try to collaborate, there's this big hurdle. And when we're in that space, when we have to innovate fast, and that becomes a big hurdle. So at the institutional level, I do agree that there should be some discussions at the higher level to make the data sharing easier.
I agree. And I think just to move the conversation forward a little bit, so I agree that learning health systems, and not just within the same health system, but inter-learning is crucial. But I do think that just because an AI algorithm or approach or a strategy of implementation works in one side does not mean it's going to work at a different side, for lots of reasons.
Right.
So I do think there is value in validating at our own sites, and that means engaging with stakeholders and all that stuff. So I think that's valuable, but I think where there's improvements to be made is the speed. So I think we do need, and that goes back to a question that we were saying. I think I think in an ideal world, in an ideal system, we would have protected, quote unquote, innovation environments, which means like something like an innovation sandbox, where our teams can pilot, iterate, innovate, and fail fast.
And early,
fail fast and fail without the fear of career or reputational consequences. I think that's key. It's not so much, well, we have to do this all over again here. That's fine. Let's validate again here and do all of this here, but let us do it in a fast-paced environment where we don't have to wait 2 years for IT to integrate, or even for IT to get to us, because we have to go through all the rest of the list of projects, and then it's like 2 years later, and you're like, well, it's not innovative anymore.
Right, and then that gets to both, because you mentioned human-centered design, right? Starting with that as a way to really ground and center the work that we're doing, so we can move faster. But then to your point too, we need to have a way, and again, I'm putting my administrator hat here on, that we also don't want to just keep doing the same operational things. We are also seeing those barriers of, the folks that are lost to follow-up on the front end, right? Trying to reach patients, and it's either one or the other, right? It's either you're calling me too much, I've gotten a call from your doctor's office and the pharmacist and everything, or it's the opposite, right? Like, I can't get you on the phone. So having a way to centralize this and working together to really streamline how we can go from starting to implementing, is a group kind of team effort. And so for Akash, for you, and kind of going from this conversation, especially you kind of being kind of early career, how can institutions better support these innovation efforts, kind of anything that you've seen and heard, experienced so far? So balancing research, clinical practice, your leadership training and development, perfect world, blue sky. What are those things that you would like on your wish list?
Yeah, I mean, I think we've mentioned a lot of them already. And I think as a fellow, I'm not really involved in a lot of these things that you guys were mentioning, reimbursements or talking to stakeholders. We see a lot of the research that's done and a lot of the innovation that a lot of our attendings are trying to drive forward. But as fellows, sometimes it feels like we're taking a back seat. And you know, that goes back to the traditional model.
Yes.
You know, we're trying to learn what it is to be a clinical doctor first, and sometimes that means putting innovation on the back seat. So I think a lot of it has to do with, you know, kind of self-interest driving us to learn about this, coming to conferences, being involved in some sort of capacity. But it is really hard to balance it all. And I think it's great to have people like you three to kind of look towards and as mentors so that we can learn how to do it ourselves too.
Yeah. Effie, same question for you. We kind of talked about IT, that being a challenge, right? Having an incubator, a lab where you can fail fast, fail early, and do these innovations. But what other kind of institutional support, administrative support, what other kind of things do you need to kind of build this apparatus so you can innovate and innovate faster?
Yes. Number one, I do think that there should be, and that's something that Marat kind of, I think, alluded to, but there should be a governance structure, a governance body that has an oversight of everything that's done, at least within the same institution, of course. So that, you know, it's one thing if we reinvent the wheel across institutions, but if we reinvent the wheel, which happens every day, we also reinvent the wheel within the same institution,
right,
because we're so siloed. That's part of why the system is broken that I opened with. So making it easy to know what everyone is doing so that we don't duplicate work. That's number one. Number two, part of that same governance structure would be to have as much as possible, but clean, reliable data. Our data right now is very messy. It's not clean at all, and that's because our system was not meant for innovation. It was meant for volumes, compliance, and throughput.
Yes.
Number three, I would also say the right mentorship. That's also critical. Is to also have the administrative mentorship support that allows us to take time out of our own
your practice kind of needs,
to do these things.
That's an excellent point. And in a previous role that I was in, we tried to do that, right, as the organization, to say, like, didn't someone do a end-stage renal disease project 3 years ago? What happened to that? So we did what's called like postmortems, where we just put some decks together of just like, here's the stakeholders, here's the data, here's why it went well, or here's why it didn't, right? And, you know, we were keepers of that information. So if that came up, we could then provide that context, you know, to folks like yourselves who are like, well, wait, why didn't this work? Or why couldn't this work? Or why am I now hearing from my chair that I can't do this? Yeah. You know, no one remembers, right? But someone has to kind of be the keeper of that knowledge. Yeah. Nino, same kind of question for you.
Yeah, I mean, I'm going to build on what you said. Like, first, like, big hurdle, we need to make IRB modern, and we need to make them, you know, more efficient in a way that to facilitate this process of iteration, and sometimes we were not going to know, like, we're not going to have those 12 weeks between each iteration to go through the full IRB. So I think that would be the first step. And the second step is some institutions, we're not there yet, but having access and digitize all your data, EKG data, have access to XML data, have access to all the echo data, and have then fellows work on different projects. Like, it's endless projects. It's amyloid, hypertrophic cardiomyopathy, AFib, all of those diseases that you can, as a fellow, take on and do that project while you're in training. So hopefully our institution, and, you know, we now have to go through a lot of hurdles to get access to EKG data, XML data, and do foundational models. Yes. So, and then the third thing is, you know, early on having those access to, every institution has some sort of biomedical engineering department, and having the collaborations with them early on when you're in training, that will be very helpful. And they have events that, you know, if you are on their listserv, there is tons of opportunities to see individuals who are interested in doing clinical AI work and partner with them.
Marat, any similar things, different view?
Well,
what do you think?
I forgot what exactly the question was. I might have involved.
So this is about institutional support.
Well, let me get, so that's what I wanted to answer. So, you know, it's funny because I run our research for the Heart Center, site-based research. And if you think, let's say all of these projects originate in research, our model of doing research traditionally set up, you need to have a coordinator, you have the IRB,
Right.
and it's not data centric. So
Right.
now over the last 4 or 5 years alone, it has changed to where instead of 1 out of 100 projects, now it's 50% of projects submitted to the IRB or proposed in front of the panel is actually data projects. Now, the funny thing is when I asked to my chief, who is the president of the AHA, is, well, you need to employ data scientists, you know,
Right.
because we don't want fellows to touch data, each independently rebuilding the infrastructure. We
Right.
want a centralized structure where ECG access, echo data access is standardized, is democratized in its access.
Yes.
And the problem is our healthcare system is not moving fast enough to
Right.
have the discussion with IP lawyers about
Right.
this language, to provide access to the fellows. The statisticians don't have sort of the experience with it's actually a structural problem
Yes.
where we are not keeping up with the times. And by the time the company wanted to deal with us on whatever project, and we get around to provide everything, it's 2 or 3 years later, and it's totally
Right.
outdated. They
Right.
moved on, and everybody's frustrated,
Yes.
and everybody wasted time and money.
Okay.
But the solution for that
Yes.
is we need to be proactive. I mean, we have this. This is in the middle of the AHA.
Right.
So I'm surprised that Monash is not employing data scientists. We need to employ the right people. As the sort of the waves moving one way, you need to provide the infrastructure for that and not put it on the hands of individual people to try to solve the problem.
100%. And modeling that too. I'm sorry, don't mean to cut you off. Please go ahead.
No.
Oh, you can say something.
Just last thing I would add is the contracts. I forgot. That is a big hurdle. So that
I
is.
triggered something.
You did. That needs to be fast.
Yes.
Oh,
So,
yes. Oh, my God,
in addition-
yes.
Yeah.
Yes.
It's been 2 years since we contracted with an AI company, and we still are not using them.
Wow.
2 years. No,
Just
you
so
can't
I'm-
make that
I'm-
stuff
but-
up.
rigmarole
So I'm
of
gonna
things.
take the administrator's hat. I hate to do this now.
I'll give- yes,
I
I'll
will
hand
be
it over.
ashamed of myself 2 years ago. But the problem is, for every week we have 3 companies that want to deal with us, and at the end of the day, 80% of all data in the world is healthcare data. Only 5% of the data is used. So we want to make more use of healthcare data, absolutely. But everybody understands the value of healthcare data. Systems understand of healthcare. Everybody wants to be, cross the path and be the Trojan horse, get into the system. But the problem is there's too many, and then once you open it up to one company, you need to also surveil it, you need to govern it.
No, but-
and if we have too many, it's
But Murat, it's not. So we are actually, if we're talking about the same thing, we're talking about we've contracted with a company and we're not using them 2 years later. So that's a waste of money for the health system.
Yeah.
It's then why are we what are we doing?
Right.
Then maybe we shouldn't have contracted.
Yep.
Right.
That's what we mean. Like if we're not
make
there
it
yet,
fast and
then
then-
we're not there yet.
Yeah.
Right.
Then you have to invest.
Yep.
It's
Right.
a return on investment, not
Right.
a return on not investment.
Absolutely.
You have to invest to see the
Absolutely,
return.
absolutely. So, and honestly, what I'm hearing too, we have a few minutes left, right? Is that the behaviors that we as leaders in any of our organizations, right, and that we're out here today, is modeling what that can actually look like in our departments too, right? When we are budgeting and hiring and whatever within our systems, we're having the training, the mentorship, right, in data stewardship, and so that way we're modeling that behavior. So it may have to come from us up, right, rather than the top down. And seeing that too, in the work that we do with Hospital at Home, is we're always having these conversations and having to keep it at the top of mind of our C-suite leaders and beyond, right, that this is the wave of the future. It may not make financial sense right now, contracting sense right now, but the need and the demand is there. And to transition to, it's what our patients want. It's what they are demanding from us when they're coming in for treatment. They don't want to have to come in and driving 2 hours to get to clinic, right? They want wearables. They want ways to better engage in their care. So, sorry, just kind of getting on my soapbox a little bit there. So as we kind of wrap up, what is that paradigm shift? And if you're 5-10 years from now, let's say, we have gotten through to our chairs and chiefs and whomever, we've gotten these systems built in a way that is interdisciplinary. What's kind of that paradigm shift? What's that change that you see in your clinics and the work? Yes, Marat, would you like to start?
Oh, actually, I was just waving hello to somebody.
Oh, okay.
That was not me volunteering. But I think the paradigm shift is new generation, as there always been a new generation to adopt the stenting,
Right.
to adopt a new novel TAVR approach. I mean, so I think we are the new wave.
Yes.
Being in this pavilion, marks and designates you as a forward thinker. I do think that societies play a role in creating an environment, shared protocol, shared knowledge. So I do think that we are on that verge to escalate, to adopt technology. I think we're obviously on the back end of this. I mean, ChatGPT is like lapping us in every regard. Patients are coming to us with ChatGPT knowledge that we don't have. So I think we either adapt very, very fast or we'll be swallowed, period.
Yes, thank you.
Yeah, another kind of paradigm shift where we're seeing is, a lot of data that is coming from the smart devices and make them like breaking down the silos and have those data be interoperable, integrated in HR, and have this like wearable collected data predict outcomes. So there's already foundational models with the Apple or Google, and those are predicting different types of disease states. So making the care more, actionable, getting more actionable insight from the wearable data is where we're going to be moving.
So kind of distilling that down so that as providers, you can just you're not having to sift through everything, but you have what you need, right it there and available, and having AI to kind of, technology to kind of facilitate that. Cool.
Yes, I agree, and I'm going to build on that. I will say that in the way I see the future, because I'm an optimist, so I think we are going to get there. I think that we're going to shift from the episodic care that we do today to continuous care, and we're going to shift from diagnose and treat to predict and prevent. So instead of treating disease, instead of sick care, I call it sick care. So instead of sick care, we're going to transition to health promotion. And instead of talking about patients, and I kind of like stopped doing it. Instead of talking about patients, we'll start talking about individuals who want to optimize their health, stay healthy, be as healthy as they can be. And we can do that, and the way we'll transform and shift is by easily integrate multimodal data into our everyday workflows, imaging, genomics, proteomics, EHR, and the metadata that Nino mentioned is all of the digital health data that each one of us generates every day that is part of our unique identity as individuals. So I think integration of multimodal data will shift.
Last but not least,
the last thing I'll add is, as a trainee, I think the only way for all this to work is really to change how we teach the clinicians, right? We have our standard way of delivering care, and I think that's changing. I mean, look at all the great technology we're seeing at the conference today. But we need to train all the clinicians how to use AI, how we're changing our standard of care, how we implement that in our patient visits, and there's going to be telehealth, physician or phone visits. I mean, there's going to be so much that we have to be trained in how to use, and not just be learning how to use it on the fly. So, as Marat was saying, it's always the next gen.
Right. Yes. So thank you so much for those last words for this session, ending it with Next Gen. So the panel part is over, but we're going to break out into some sessions. If you all want to have conversations, we have table leaders. Our table leaders, you want to raise your hands? So we have some folks too that are representing here for the panel for our table leadership. So thank you, everyone. Thank you for coming and joining the conversation.
Thank you. And we're going to do one team photo. We also have a pen and a ribbon.